Good morning, and thank you for joining us today on August 16th for this media briefing with Dr. Lisa Piercy, the Commissioner for the Tennessee Department of Health. I know most of you are used to this format by now, but just to run down logistics, we will start with some opening comments from Dr. Piercy, providing an update on a few points since the last time we gathered together for an update on the COVID-19 pandemic in our state. We will then have a few moments for a question and answer period. If you would like to ask a question, please use the raise your hand feature on WebEx, and I will call on you to unmute your microphone at that point. Please leave your microphone muted while others are speaking, as I know that several are live streaming this media briefing today. With that, Dr. Piercy, I will turn it over to you for opening comments.
Thank you, Sarah. Good morning, everyone. I've got three major topics to cover this morning. And some of them have quite a bit of technical detail, so I'll be referring to my notes a good bit, and I'm happy to clarify or repeat anything that you may have missed. The first and top line today is about our hospital capacity concerns. We are having hospital capacity concerns on both the pediatric side as well as the adult side. And there are a lot of different factors that are coming together to cause that. One of those, and it's very different than it was back in the winter when we had our surge, is that the hospitals were really quite full before this surge even began in July. You've heard me speak before about pediatric hospitalizations being primarily driven by RSV and other respiratory illnesses that we typically don't see in the in the summertime. We typically see them in the wintertime. That is still true in our children's hospitals. And to some extent, that is what is also driving increased capacity in adult hospitals. But it's also other things, and it's a whole host of other things: heart attacks and strokes and traumas and things that are normally in the hospital, or patients that are normally in the hospital, were already causing hospitals to be full. So I want you to keep that in mind, because when you look at our hospital numbers statewide right now, and today it's right at about 2,200 hospitalized patients, it would be natural for you to get a little confused and say, well, in January, our peak hospitalization number was 3,300, which is, quite a bit more than 2,200. Why such capacity concerns now? Well, it's primarily because of the occupancy prior to the surge. It's because the staffing concerns that we've had, and we've had them in hospitals for years, and then we have them even worse now because there are nurses that are getting sick, and not just nurses, but all staff. There are people who have left the workforce, and staffing difficulties just like every business is having. And so when you have kind of an already full hospital with staffing and worsening staffing concerns on top of that, when you put extra COVID patients on top of that, that really tips the scales in a lot of the situations. So let's break that down between pediatric and adult. It is still true that the vast majority of pediatric hospitalizations are not COVID. Yes, our COVID pediatric hospitalizations are going up, but that is not what is driving those pediatric hospitalizations. I covered that fairly extensively in my briefing 2 Fridays ago, so I won't reiterate that today. But our adult hospitalizations are continuing to go up quite a bit, and a lot of the capacity concerns in adult hospitals are because of COVID. Right now, as I mentioned, we have about 2,200 hospitalized Tennesseans statewide. Those are almost all adults. Over the weekend, we had 50 children hospitalized statewide. The latest numbers, I think, is down to 45. That will fluctuate, but the vast majority of hospitalized Tennesseans are adults. An interesting and startling statistic is that in the first 15 days of August, we've had 1,023 hospitalizations. That is higher than any other full month combined in the pandemic, which was November, and it was in the 900s. So we've already had more hospitalizations in the first half of August than we have in any other month, total month in the pandemic. Likewise, our ICU numbers are starting to climb very rapidly. At last count, we had about 662 Tennesseans in ICUs, which is about the same peak that we had last winter. The startling statistic there is 40% actually a little more than 40% of all ICU beds in the state are filled with COVID patients. I do want to reassure you that still it remains to be true that the vast majority of hospitalized patients statewide are unvaccinated. We do update our breakthrough rates on our critical indicators report every Friday. And at last count for the last few months, May through July, 88% of hospitalizations were unvaccinated and 94% of deaths were unvaccinated. So the message hasn't changed. Vaccination is still the single best tool we have to prevent against serious disease and death. Now let's talk a little bit about what the 10 or so percent of people who are becoming hospitalized who are vaccinated, what that is. In most situations, those are people who are immunocompromised. And I have some comments later about that. You've heard about the third dose booster recommendation, and so I'll cover that today. But I want you to know that the vast majority of people who are in the hospital are unvaccinated, and those who are vaccinated by and large have some type of immune system disorder, either naturally or because of medication that they're on, that is causing them to have these more severe breakthrough infections. So let's talk about what everybody is doing because of this situation. So the state has actions, the hospitals are taking actions, and I have actions that I need the public to take. So on the state's perspective, a lot of the things that we have reinstituted in the last several days are things that you will remember from the wintertime surge. One of those is very important to our hospitals, which are the regulatory flexibilities offered in Executive Order number 83. And that might not mean a lot to some of you, but what it essentially means is that you can take your current hospital personnel in all different job categories and actually have them sort of move up a level, and so you can backfill with lower skilled workforce. Saying that a different way, the people who are working in a hospital, we are relaxing some of those regulations where they can do more and do more functions and serve more patients in order to stretch the current staff further. You've heard me say many times that the major part of hospital capacity is staffing. And staffing is in demand all over the nation and specifically in the South. And so workforce that we've had have either left the workforce altogether, or some of our healthcare workforce is going to these agencies where they are being pulled to other hospitals, some in the state, some not in the state. So we have to make our current personnel able to tolerate all of the different tasks that are going on in the hospital right now. Something else that we're doing that you'll recall we did back in the wintertime is we're providing assistance to hospitals because this agency staffing is very expensive. And so we are able to use some of our federal relief dollars to provide hospital staffing assistance grants. That is just a resurrection of the program that we had back in the fall. And then probably the most visible strategy that we have right now is starting today using our National Guard to supplement staffing in hospitals. And so when we have personnel in our military who can do medical procedures or have medical training and can backfill in hospitals, that will help augment the staff that is already there. We did that in some situations back in the wintertime. We are reinstating that program as of today. And so depending on the size of the hospital and the amount of their need, we are taking some of our National Guard personnel and augmenting staffing in those hospitals with that personnel. So those are the actions we're taking as a state, but the hospitals are taking action as well. Some of them have already begun to stop elective procedures. And you might think, well, what does an outpatient procedure have to do with an inpatient bed? Many of them have already stopped or really slowed down on any type of procedure that causes the patient to have to stay overnight. And so that this is driven by the hospitals because they know that they need to have those beds open. But what you're also starting to see is that some hospitals, when they have outpatient surgeries, even those that are not expected to stay overnight, they will delay or stop those for a temporary time to use the staff in those facilities and in those different situations and bring them to the bedside. It's in the same theme of trying to have, since we can't infuse big droves of staff, to use the staff that we have more efficiently so we can serve the increased number of patients. The other things that you have already seen some hospitals statewide do is begin to erect additional spaces, usually outside of an emergency department or near to the hospital, where patients can be triaged or evaluated before they come into the hospital, because this is all one system. And so if your beds are full, then things start backing up in the emergency department. And when the emergency department is backed up, then people have difficulty whether they come in on ambulance or come in by car to be evaluated. So you will see these extra facilities being put up near or outside of emergency departments for that. You very likely are to experience delays if you go to a hospital right now. And therefore, this is where I transition into what the public can do to help. If you don't have a true medical emergency, please do not go to the emergency department. Go to a level of care where you can be evaluated and then discharged if you don't have a true medical emergency. Obviously, if you're unsure or if you are in any kind of distress, you do need to go to the emergency department. But if you've got something that could be taken care of in a lower level setting, like in a clinic or an urgent care, strongly encourage you to do that to help with the throughput in those emergency departments. The other things that the public at large can do are no surprise. There is no one within the sound of my voice who doesn't already know what he or she should do to protect themselves. But I will say it again, please get vaccinated. If you haven't been vaccinated already, it's not too late. We still have lots of vaccine available, walk-up availability. I would guess, I did a little experiment the other day just in my normal day-to-day business. I encountered 2 or 3 different locations that I was already visiting that had vaccine available. And so it's convenient, it's safe, it's highly effective, and it's not too late. Please go ahead and do that. The good news is that a lot of Tennesseans are doing that. Just in the last month, our week over week vaccination rates have doubled. We went from around 58,000 a week to now over 100,000 a week, and many of those are first doses. So Tennesseans are coming in higher numbers to get vaccinated. That's exactly what we need. And please know that it is not too late if you haven't done that already. And then the other thing that you know what I'm going to say, but I'll remind you anyway, if you are sick, please stay home. And if you are having symptoms, even symptoms that you might perceive as mild or not very unusual for you, I encourage you to consider getting tested, because particularly if you've been vaccinated, the breakthrough rate is not very high, but those symptoms can be very mild. You are still contagious. If you are having symptoms, whether you're vaccinated or not, I encourage you to get tested, and please, please stay home until you know whether or not you are infected with COVID. Also, be smart about when you go into crowded areas, and don't forget about wearing your mask when you're in high-risk environments. Now, let me shift to a couple of more things that the public at large and individuals can do to help with this hospital capacity, because it would be very natural for you to think, well, I can't do anything about that. I don't have nurses I can send. You can't, you don't. Oh, we understand that. But what we can do as a community and as a state is try to reduce the demand on our hospitals. I'm going to talk about something that has been around for several months now, 8 or 9 months now, but I'm continually surprised at how few people know about it. It's incredibly, it's incredibly effective against infection, and that is called monoclonal antibody. Now, that is a big mouthful, but it is essentially where in a pharmaceutical laboratory, you can manufacture antibodies that will fight COVID infection just like your own body would. So your natural immune system is going to start fighting it off. But for a lot of people, particularly those in high risk categories, they could use a little help. And so this is a medication. Some people call it a therapeutic that you can take to prevent the progression of your disease. It's essentially boosting your own antibodies and your immune system. It's been around since November of 2020, so we've had it for about 9 months, and there are actually multiple different products and manufacturers of that. The best news is that it is in full supply. We have no shortage. We have it available all over the state. Primarily, it is given in an IV infusion. It takes about an hour, and then they watch you for an hour. I promise you, if you are high risk and you get infected, there is no better 2 hours than you can spend of getting that infusion, because it is so highly effective of keeping you from progressing to the need of hospitalization or even more severe disease. But there are some people who it is more geared towards. So I told you it can be an IV infusion. Now, in some instances, they can also give it to you subcutaneously, which is basically a shot, but the best way is still in an IV infusion. So if you get a positive COVID test and you have had symptoms for less than 10 days, and you are at risk for progressing to severe disease, that means you have underlying medical conditions or you are of advanced age. And I'm not talking about really serious medical conditions, even common medical conditions like hypertension, high blood pressure, and obesity. Those are risk factors, diabetes, those are risk factors for progression to severe disease. So if you are a high risk individual, either by your age or your medical condition, after you get that positive COVID test, your very first call should be to your doctor or to a facility that has monoclonal antibodies in order to go ahead and get on this schedule and get that infused. Now, we do have a listing on our website, the Tennessee Department of Health, that has 72 facilities statewide where you can get this. We actually know that there are about 139 locations statewide that have received the product, but the 72 facilities listed on our website have them. They're readily available, and most of them are hospitals, some of them are clinics, but you should take a look at that list, and that should be your first call after you get that positive test. I'm sure you've probably seen in the news about these mobile units or other things that states are doing. The good news is we've got a really robust system in Tennessee and have had for several months that has the product available, and they have a very well-established system where you can go get in and out, and it has a significant reduction in your risk of being hospitalized. So not only that's what you can do for your own health, but that's also what you can do to reduce the demand on hospitals. Finally, let me talk a little bit about third dose boosters. This was late last week, Thursday and Friday. You probably heard statements from both the CDC, ACIP, and FDA related to this. And I will tell you, there are some more finalized guidance to come in the next few days, but I'll tell you what I know right now. So FDA has authorized a third dose booster of Pfizer and Moderna for individuals who are immunocompromised. Notice that I did not mention Johnson & Johnson. That is currently not authorized, but for those who got 2 doses of Pfizer or Moderna, they can get a third dose booster in some situations. You must wait 28 days after your second dose to get that third dose booster, and you preferably need the same kind of shot that you got or the same brand that you got the first time. You'll remember from months ago, we talked a lot about vaccinefinder.org. That website is now transitioned to vaccines.gov, vaccines.gov, and you can find the website there, and it will tell you which locations have Pfizer, which locations have Moderna. Again, you need to have the same dose that you had the first time, although that is not an absolute, that's not mandatory, that is what is recommended. There is a long list of conditions that people have that qualify them for a third dose booster. They're very detailed, they're very technical, but let me sort of hit the highlights for you. If you are in active cancer treatment, you probably need a third dose booster. If you are a transplant patient, whether that is an organ transplant or a bone marrow transplant, you probably need a third dose booster. If you have an immunodeficiency, those types of diseases that cause your immune system to not work as like it should. Those are relatively rare, but if you have one of those, you're certain to know it, and you probably need one. Likewise, advanced or untreated HIV needs to have a third dose booster. And then another category, and it's probably one, or certainly one you need to talk to your doctor about, is if you are on medication that causes your immune system not to be as strong as if you weren't on that medication. We call those immunosuppressants. The most common one is chronic high dose steroids. There are a lot of people with chronic inflammatory conditions that have high dose steroid regimens. Those and other drugs like chemotherapy, things that reduce your ability to fight off infection, you need those third dose boosters. So the most important part of all of that is if you think you qualify for a third dose booster, you need to be talking to your doctor. Your doctor may already be reaching out to you to tell you that. And anywhere where you got a first or second dose, you can get a third dose, including health departments. Back in April, we stopped. You can still get an appointment, but it's just walk-up availability with essentially no wait. So if you qualify for a third dose, you don't have to show proof of that. You just go to one of the vaccinating sites and tell them that you are there for your third dose booster. As long as it's been 28 days since your last dose, you are eligible to get that beginning today. I will stop there. I'm sure there are a lot of questions, and I know I've spent a big portion of the time talking, but happy to take any questions you might have.
Thank you. We will start with Stacy Case. Stacy, please unmute your mic and ask your question.
Thank you, Dr. P. You covered pretty much everything I wanted to ask with the situation we have with the COVID surging right now. But I do have one related question. We have had some people reach out to us concerned that anyone could access someone else's vaccine records on the Department of Health website. Are there any plans to require more secure verification, maybe a driver's license number or Social Security?
Absolutely. So patient privacy not only is the highest concern of Tennessee Department of Health and state government, but quite frankly, as medical professionals, we hold patients' information as tightly as possible because that is only due to that patient. And that goes for vaccine records or any other medical record. Patient privacy is our utmost concern. And so any type of vaccine records, patient portals, any of that, we are putting in all of the layers of verification. So only the people who are due those records are getting those records, and that is only at the patient's request.
Thank you. All right, next question is to Tosin. Tosin, please unmute your microphone.
Good morning. Thanks, Dr. Pearson. You covered a lot of stuff I had questions for. Just two things. With the rollout of the additional dose, when people go to like the health department, do they have to show some kind of proof since it's so specific for those who need that additional dose? And my other question was, does the state still do contact tracing for schools? So say, for example, in Sumner County schools, if there's an outbreak of sorts, does the state still do that? And if so, how does that work?
Sure. Yeah, those are great questions. So there is no proof required. If you believe you qualify for a third dose booster, you go to any vaccinating provider and they should be able to get you your third dose right away. Certainly the health departments, I can speak for them directly. We do not require any documentation, but we do encourage you, if you don't fall squarely in one of those categories, people obviously know if they've had a transplant or not, they know if they have HIV or not, but if you're not sure about your treatments or your medications that you're on, be sure and talk to your doctor. And then if your doctor or medical provider says, yes, you qualify, go right to the health department or any medical provider and get that third dose. Related to contact tracing, we are actively talking to schools right now and helping them whenever they need help. So there's a mixture. Some schools want to do it themselves. Some schools want to use the health department to do that. And there are a lot of different iterations and variations of that all over the state. But for those who want the health department to assist, we absolutely are doing that. As you can imagine, we're very busy right now doing contact tracing just like we were in the wintertime surge. And so some of those calls may be delayed, but we are mobilizing volunteer staff. We're mobilizing contract staff in addition to our own staff to help do as much contact tracing as we can.
Next question is to Brett Kelman. Brett?
Good morning, everyone. last year, when we were in a similar hospitalization surge, there was a lot of to-do made about two overflow facilities, one in Nashville, one in Memphis, designed to take patients if necessary. I'm curious if those facilities are still ready to go if needed, if we've reached the point to where it's time to activate them, and if not, what the limiting factor is. And I'm going to assume it's probably a matter of staff, which raises the question, if the state needs these facilities, how is it ever going to get the staff to use them?
Yeah, those are great questions, Brett. And our alternative care sites in Memphis and Nashville have already been demobilized. So the ones that we had in those two cities are no longer available to us. Now, what we have learned over the last 18 months or so is that those single geographies don't work as well as when we have something in most every community that has a hospital that is overflowing. For example, if a patient in Greene County or Washington County were to need an overflow bed, going to Nashville or even Memphis certainly is not feasible for them. So it's a lot more practical to have that on site or near site. But as you mentioned, the key component there, the rate limiting step, is staffing. And people all over the nation, certainly all over the state, but also all over the nation, and particularly in the South, are competing for the same staff right now. And that's why we're trying to do everything we can to not only stretch the staff that we have, and please, let me take this opportunity. Please tell a healthcare worker thank you, because they are being very, very stretched right now, and they are working themselves day in and day out to serve our community. So thank a healthcare worker. But we're taking that same staff and trying to get them to work at the tops of their license so we can backfill lower level staff and stretch that staffing efficiency. Likewise, that's why we're augmenting our staff with military personnel, many of whom are medically trained, some of whom are not. And so if we have medically trained people doing non-clinical work in hospitals, and that does happen sometimes, we can backfill that with a non-clinician so those clinicians can go closer to the bedside and help where only those clinicians can. So I don't have a lot of quick and easy answers for you. Staffing is a major concern. It has been a concern, and it's something that we're trying to pursue every avenue to address.
Just to be clear, what does demobilized mean in this context?
They
Those facilities don't exist anymore?
the physical shells of the buildings exist, both at the former Commercial Appeal Building and Nashville General, but all of the extra equipment and setup, medical gases, all of those have been demobilized based on FEMA requirements.
Thank you, Dr. Pearson.
Next question is to Blake Farmer. Blake?
I have many questions, but I'll limit it to this. And I guess it is when I don't remember seeing many guardsmen in hospitals last time, and I don't think it happened to much extent. Maybe there was some testing or something they would take over. But are you expecting them to be more widely used now? And like, what kind of numbers are you all, I don't know if activating is the right word, but how many folks are potentially headed out to hospitals?
Sure. So the details on the exact numbers, I would defer that to General Holmes over at the National Guard. But we are taking many of the National Guard staff that have been giving vaccines. Obviously, that has slowed down quite a bit, and shifting them and redeploying them to hospital settings. You're correct in that we didn't do a lot of that back in the winter. Based on my memory, I know we did it in Northeast Tennessee, and I believe we had a team in Memphis. These are relatively small groups, 12 to 15 or so, that go in and help backfill. And so the criteria to qualify for one of those teams is pretty high. The bar is pretty high, and I can't tell you all of the criteria right now, but it has to do with how much capacity the hospital has left or not, and then what they're doing as far as mobilizing their own staff internally. And essentially, when hospitals have checked all of the boxes of doing everything they can, then we can augment their staffing with the Guard. As opposed to the winter, many more hospitals are nearing that point now than they did in December and January. So I do think you will see more guardsmen at hospitals than you did back in the winter.
And just a quick follow-up. I mean, are there any folks who've already qualified and are sort of just waiting for folks to show up? And what part, it's supposed to be western part of the state? I don't know.
It's really all over the state. Certainly, our Memphis hospitals have significant concerns based on their proximity to Missouri and Arkansas. The surge hit them a little sooner than it did in other areas of the state. But as I know you've seen reports of, there are hospitals with capacity concerns all over the state. Those guardsmen have been gearing up over the last few days, and then today will be the first day that we are actually instituting that criteria and starting to mobilize this staff out to different parts of the state.
Thank you.
All right, thank you, everyone. That concludes our briefing for today. We appreciate you joining us for this information.
Sorry, I didn't
We'll
get-
be ending the call today. Thank you.
Get a question in. I'm sorry.